Good morning. Finally a thaw a little bit. My name is Red Schiller. I'm Vice Chair of the Department of Family Medicine and Community Health at Mount Sinai and Chief Medical Officer for the Institute. We could start this morning with a relaxation exercise, but I'll leave that up to my dear friend and colleague, Ben. Just to say that this is actually a really special presentation. For many of us, what integrative medicine means is really, I had to rush to get here, so give me a moment. But what integrative medicine is really about, in some ways, is restoring healing and emphasizing the importance of a relationship that goes beyond just the clinical discussions that we have to people's, if you pardon the expression, soul. When people come to us who are really troubled and struggling and they have healthcare problems, but the things that and the work that Ben's done for much of his career really represent what I'm talking about. I can't think of a better person to be able to discuss this than Ben, who's been a friend and colleague for many years. So we're really glad to have him. A few comments about what he's accomplished. He's currently the National Director of Integrative Health Coordinating Center, out of all places, of Veterans Health Administration, which is really impressive, and in some ways, we can learn a lot from what the VA is doing, and perhaps Ben can tell us a little bit about that. He's former chair of the Department of Integrative Medicine at Mount Sinai, Beth Israel. That's a whole other discussion, probably a separate grand rounds about what happened there. He's currently professor of family and community medicine here at Icahn, and the founder of Integrative Family Medicine Fellowship that we've had at the Institute for a number of years. He's the former chair of the Academic Consortium for Integrative Health and Medicine. This is a national organization that coordinates academic programs in integrative medicine, and co-editor-in-chief of the peer-reviewed journal Explore. He's a pioneer, a thought leader, and a really nice guy. So, thanks, Ben.
I hope someone taped that introduction for my family. Thank you. Yeah, really, thank you, Red, and thank you for having me, and I'm excited about the talk. I can't not take the challenge that Red put out of just taking a moment, because in integrative medicine, we do try to walk the walk and not just talk the talk, so why doesn't everybody, we'll do it really fast, because I have so much to say in the next 50 minutes. So just take 1 minute, 30 seconds, 10 seconds, just take a deep breath. Great. And not to sound corny, but what would the world be like if everybody just did that one time in an hour, right?
Before they tweeted.
Yeah. Enough said about that. Okay. So my topic is integrative medicine as it relates to health disparities and to working with underserved populations. And I do want to just acknowledge Red's commitment to this, in that the Institute and the Department of Family Medicine at Beth Israel was doing this way before it was trendy and popular, and this goes back to really 1995 is when I came to the Institute, and that's a long time ago now, and it was not a time when this was mainstream the way it is now, but Red has really been committed to it in a way that's really actually had an impact nationally, and I think that needs to be acknowledged, so thank you, Red. Okay, so this is what we're gonna do, and I will probably talk fairly fast and hopefully have a little time for questions at the end. We're going to talk a little bit about the evidence for the effectiveness of some of these integrative therapies. Very little about it, more just to sort of demonstrate to you that it's there. We're going to talk about specific strategies for doing this in the underserved setting outside of the patient encounter, outside of the physician-patient encounter, because I think that's really key. We're going to talk about pros and cons of doing this in a group setting, because obviously that's one of the keys to making this available in a economically challenged clinical setting and population. And then we're going to talk about a couple of trials that we have been doing in our research program of group-oriented interventions for chronic pain. I titled it, Health Disparities. Mostly I'm going to be focused on pain and mental health conditions because I think that's where the evidence is strongest, and so that's where we're ending up focusing both our research and really our clinical programs to some degree. And I just want to start by saying I know there can be a feeling when one works in a community health center, or we go through this a lot in the VA, because complicated patients, complicated social situations, complicated medical situations, feeling overwhelmed as the clinician, I don't have time for integrative medicine. I just have too many other things to worry about that are pressing priorities. I've got these best practice alerts on my computer screen. I've got people with desperate social problems. And we hear this as much in the VA as we do in the community health center setting. And so the whole goal of this is really to say, this is not about you, the physician or the clinician, doing more. It's about a small shift in thinking and then a larger shift out of the box in terms of thinking about how we deliver this care to the patient. So that in the long run, this should lead to easier job for the clinician, less burnout, more options, more empowered patients. So just to quickly review, and Red really went over this, what do we mean when we talk about integrative medicine? I do want to be clear that although I'm talking a lot about modalities here, like we're going to talk about acupuncture a lot, for example, integrative medicine is not modalities. Integrative medicine or integrative health is really an approach and an attitude and a philosophy. And fortunately, it's very congruent with the basic philosophy of family medicine. Sometimes we diverge from that in actually the practice of family medicine because we get caught up in a very disease-oriented model. But the truth is family medicine originated from the concept of treating the whole person, empowering them in the context of their family and their community. So it's really very congruent, and it's one of the reasons family medicine has been the most productive home for integrative medicine over the years, at least in the States. So integrative medicine is about enabling the intrinsic healing properties that exist within everybody. It's about an openness to a wide range of therapeutic approaches. It's about looking at the whole person, and I know that none of this is new. It just is good to remember, and really a commitment to empowering. And I think this is really important because when we get to talking about the sort of specifics, and all of which really in this scenario happen outside of the physician-patient encounter, the empowered patient ultimately equals less work for the clinician because they handle more on their own, they make better choices. It's not just kind of talking about what you feel they need to do. It's about working with them together to understand what matters to them and then building the plan around that. So again, I know none of this is new, but I think it's important to keep it front and center as we move forward. It's very easy to fall into, we are physicians, we treat diseases, boom, end of story. It's just too much pressure on us to do it that way, so we need to actively be cultivating and remembering the bigger mission. So first thing I'm going to do, and I'm going to do this quickly, is talk about the evidence. So once upon a time, the question about integrative medicine was, does it work? Is there evidence? And that's still a fair question about a lot of approaches. Let's think out of the box. Aromatherapy, Reiki, lots of questions about effectiveness. But when you talk about some of the main modalities, and I'm mostly going to talk about acupuncture and mind-body therapies, this is resolved. This is over, the question of whether there's evidence. And I know that people don't know that yet, and many of your colleagues in the medical center don't know that yet. And it's new. It's a new era in integrative medicine. It really just started in the last year or two, but it's different now. And so it's no longer a question of should we do these things because do we know if there's evidence? It's really a question of how should we do these things because patients deserve them, because there's evidence. So just in a quick nutshell, this is just one example. So look at the top, ACP. I don't know if people know about ACP, American College of Physicians. So if you were going to identify, I don't know, without offending anybody, if you were going to identify conservative medical establishment organizations, there's the AMA, number one. AAFP is up there somewhere, but probably 3 or 4. and there's ACP, which is the Professional Organization of Internists. So this is a massively conservative organization. This is an article describing a set of guidelines that came out in March of this year, non-invasive treatments for acute, subacute, and chronic low back pain. So this is an official practice guideline from a very large mainstream medical organization, and highly recommend everybody read this, but I'm just gonna focus on two things. So they did a massive, as you can imagine, review of, a really exhaustive review of the literature around treatment of pain. And this is focused on low back pain, just to be clear, because they have to focus, when you do evidence guidelines, obviously you have to focus on a specific condition. But a lot of this applies to other pain conditions too. So what did they say? So regarding acute or subacute low back pain, and I don't usually read slides, but I'm gonna read a lot of this. Low back pain usually improves over time, regardless of treatment. That's good, we know that. Clinicians and patients should select non-pharmacological treatment first with, and here's a set of options, including massage, acupuncture, spinal manipulation, by which they mean osteopathy, chiropractic, etc. And they do say low quality evidence, but note that it's a strong recommendation, meaning the balance, the risk-benefit balance strongly favors doing this. So that's acute pain. And probably more importantly, given the impact of the opioid epidemic and the impact of chronic pain, just read this one. I'm just gonna let you leave this up for a minute. For patients with chronic low back pain, clinicians and patients should initially select non-pharmacologic treatments, exercise, multidisciplinary rehab, acupuncture, mindfulness-based stress reduction, Tai Chi, yoga, relaxation, etc. So I'm just gonna say this one more time and then we're gonna move on, because I'm not gonna show you all the studies. I didn't want to spend my time on that, but I'm just gonna say it one more time. One of the most powerful mainstream medical organizations in the country recommends acupuncture, mindfulness meditation, Tai Chi, yoga as first-line treatment for chronic low back pain. Okay, so if we are not thinking of those things when we see a patient with chronic low back pain, we are not practicing at the standard of care. Period, end of story. So I know that is probably different from how some of you are thinking, and some of you haven't had the opportunity to learn enough about these modalities yet, but this is just a fact of life that everybody has to deal with. Here's another article if you're interested. This is put together by the staff at the National Center for Complementary and Integrative Health, which is the NIH branch that supports research in integrative medicine. So this is the staff there looking across the medical literature and making their commentary about where's the best evidence. Very similar findings. It's a little broader than just low back pain, but you can see that the effectiveness of acupuncture, of massage, of relaxation techniques comes through very clearly in this article, and this is in Mayo Clinics. So that's really all I'm gonna say about the evidence. I'm happy to take questions. I'm happy to do another talk about more evidence if you like, or about some of the controversial subjects where the evidence is more murky. Regarding pain, it's a done deal. So I briefly want to mention then, so the world that we're living in now is informed by this evidence, or will be soon, but the world we live in is also informed by the organizations that govern us, of which, as we know, Joint Commission, you know, oh my God, but I said it, Joint Commission is one of the governing organizations. So I just want to share this briefly because, again, this goes to, as physicians and healthcare givers working with underserved populations, we know we have to be activists as well as clinicians, and we know we have to have us, and I mean Neil and Red are great examples of this, we know we have to have a vision of what our patients need that doesn't exist, and we have to try to move politics, policy, health economics toward that vision. So I just want to call out, there's a wonderful acupuncturist who's part of our department, Arya Nielsen, who took on the task of getting Joint Commission to look at how much its emphasis on pharmacologic treatment of pain was contributing to opioid epidemic problems with the way chronic pain is treated. And back in 2014, she wrote a letter, believe this or not, she sent an email to the medical director of Joint Commission, just cold. He didn't know who she was, nobody knew anybody. We really think you should look at this. And she got me to sign and some other people to sign. And I was like, they're never gonna answer you. You know, what are you, crazy? And the guy answered. And the guy said, you know, this is interesting because we have been looking at this and there's been a buzz about how by increasing the emphasis of pain as the fifth vital sign, and not emphasizing that non-pharmacological treatment was appropriate, we may actually have contributed, he didn't actually say this, but this was between the lines, we may have contributed to some of this overprescribing. And so basically that started a whole process where they recruited Arya to be one of their subject matter experts. She worked with them over the course of 2 or 3 years. Initially, there was a non-bonding recommendation. And then as of January this year, so this month, please read the bottom bullet, hospital provides non-pharmacologic pain treatment modalities. So this may seem minor to you, but this is huge. When you talk about the world we practice in, Joint Commission, as you know, hospitals that get dinged on Joint Commission surveys, their reimbursement from Medicare and Medicaid can suffer, so this is something that strongly motivates hospital leadership. And there you have it. Now, it doesn't dictate which non-pharmacologic modality, so it doesn't say hospitals should offer acupuncture, hospitals should offer mind-body therapies. But if you take the leap and say hospitals should offer evidence-based non-pharmacologic pain treatment, and then you just go back a couple of slides to, where is the evidence, it's a no-brainer. And this is having a huge impact already on hospital leadership around the country in terms of these things are now mainstream. They are part of the package. And I'll also say in my VA role, my job is to help promote complementary integrative medicine across the VA. VA is now paying across the board for acupuncture for veterans, mind-body therapies for veterans, chiropractic for veterans, massage, Tai Chi, yoga. It's part of VA medical benefits across the board, across the system. And this wouldn't have happened if this wasn't that. This is now what was standard of care. This is the evidence-based standard of care. Okay, so enough about that. I hope I convinced you. We can talk about it at the end if I didn't. So I want to take for granted that this is now something we are going to do, and that we already have a lot of things to do as clinicians working with underserved populations. And so we want to figure out how to do it. I want to show you some out-of-the-box ways of thinking about doing this, ways of thinking about delivering this kind of care to patients. And what I want to point out, and Ray and I were talking about this as I was preparing this, the Institute and the Department of Family Medicine is already doing actually all of the things I'm going to share with you. We've got our toe in this water. We're trying out some of these things already. And so that's really exciting. And what I want to share is what it would look like if we did this in a bigger way, in a more comprehensive way, because there are places that are doing some of these approaches in a bigger way and really having a big impact. But the exciting thing is there's the groundwork here and there's experience already with all of the things that I'm going to talk to you about. I do want to just acknowledge these folks at the bottom who run those top 3 programs and are really wonderful people doing a great job. So the first example, is there a clock somewhere, Diane? Are you the clock? Yeah, but it's 8:24. 8:24, okay. Tell me when it's 8:40. Yeah, just raise your hand. Okay. Okay, so here's the first model. Group visits. We do group visits at the Institute. We have been doing them for a long time. We do centering pregnancy. We do other groups, etc. Our fellows have run some groups. At the same time, we don't do it on a huge scale, but there's yoga groups, etc. There's a lot going on. So let me tell you about Greater Lawrence Family Health Center. Lawrence is the poorest city in Massachusetts, predominantly Latino population, very big, busy health center. They have a couple of sites. I think this mostly happens at their main site. And they have had for about 15 years a commitment to a group-oriented approach, not just to deliver integrative health, but to deliver patient-empowering healthcare. And so they've taken this to all kinds of topics. They do prenatal groups, obesity, smoking cessation, heart disease, etc. And they also use the groups to deliver treatment modalities like acupuncture. At the time that Jeff sent me the slide, they had 38 weekly groups running, which is pretty crazy. They actually started this with some grant funding and now have figured out a way to keep most of it running by billing actually for some of the groups and by having some of the groups be patient-led. So there's actually no cost other than space. So they have 2 models of how they do the groups. This bottom one, what they would call an enclosed model, is more like a traditional way of doing a group. So this might be an 8-week diabetes group with a specific curriculum. It might be an 8-week mindfulness meditation training with a specific curriculum, and it ends, and it's taught by, quote, an expert or a faculty person or a clinician. And then they have an open-ended model, which is really interesting, which is a group that just goes. And it's a drop-in group. You don't have to be there for any set number of visits. And they tend to be focused around issues so that people in the group have a similar set of issues to share. And they're generally started by a clinician, often a social worker, sometimes a physician. And then over time, the leadership is often handed off to a patient. So these are the subjects that they've focused their groups on. And so you can see that the open-ended models, a lot of them do revolve around sort of specific diagnoses like weight loss or chronic pain. And then they have these specific kind of shorter term and closed models like prenatal groups, acupuncture groups, et cetera. So very wide open, kind of wide ranging approach to using group care. And I think what's neat is that it isn't entirely dependent on the clinician. When they have clinician-led groups, they have 2 staff people. They'll have a social worker or another mental health person and a clinician. The clinician is available for pull-out visits. So when people arrive at the group, they sign a thing if they want to have a private minute with the physician. There's a little room on the side. They do 5 to 10-minute pull-out visits with the patient. And so at the end of an hour, they're billing for 4 or 5 brief visits. So the physician's time is covered plus, and meanwhile the group. So the physician is sometimes in and out of the group, but the group is continuing. So they've got a really nice model for how to get the groups where they need a physician, how to get the time supported, and how to get increased access for patients as a way to help them move forward with their care. Pretty neat. The exercises aren't just great for losing weight. They relax the mind, helps me make new friends. We treat each other like family. When someone doesn't come on a particular day, we're already missing each other. So I think what this emphasizes, and I know this is obvious, is the power of the sort of social engagement that comes from doing things in groups. And that's a power that we don't have as physicians or clinicians in a one-on-one encounter. So this is a way of accessing something about people that we can't do by ourselves that potentially helps them move towards more health. It's pretty exciting. And they do have some data that's been published. There's an article that came out a couple years ago in Explore. I know they have more data that they've got now about outcomes. They're not randomized trials. They're just, sort of prospective cohort trials, but they've got some really nice data about outcomes, and including around weight loss, which, as we know, is really tough. Okay, so group model. Let's think about building out our group offerings. Here's another model. And again, something that we're doing, increasing access by bringing complementary integrative health trainees to the community setting. So this is something we're doing. Ray has started a relationship with Pacific College of Oriental Medicine. Trainees are coming in. I hope we're still doing it. Yeah. Okay, great. Trainees are coming in. Move it to 17th Street. Yeah, great. Excellent. With their preceptor and treating patients. So basically no cost to the institute other than space. They handle their own issues, their own malpractice, et cetera, and our patients get a benefit. So here's an example of a place that has done it on kind of a massive scale. Venice Family Clinic is a very large community health center operation in Los Angeles. They have multiple sites, 24,000 more or less patient population. I think it's probably bigger now, 106,000 visits a year. You can see what the population is like. And this is a program that was started, I think, about 9 or 10 years ago now by Miles Spar, a wonderful guy. And they focused initially, and I think they mostly still do, on a chronic pain population. And basically their whole strategy is they've built relationships with schools of complementary integrative health in the Los Angeles area. Chinese medicine, acupuncture schools, osteopathic schools, chiropractic, massage, physical therapy, social work programs. And basically they've just got students and interns from those programs flowing into their integrative pain clinic and providing the care. And they come with preceptors, obviously, who are supervising them because it's part of their clinical training. And so this is obviously not a model you could do in Paducah, Kentucky, because you don't have these schools available, but we live in New York, and we really have begun to advantage some of this, but not thoroughly enough really yet, and there's lots more opportunities. And they've actually, this data is a little old. I think they're continuing to collect data, but this is on 3,000 patients who they had seen as of June 2011. You can see what their demographics are like, and you can see what their income level is like, and they basically were focused on pain. They used a brief pain inventory, and this was their pre-treatment, this was their post-treatment. This is significant improvement in the severity of pain going out to, I think they did, I can't remember if it was 24-week follow-up. but persistent after the treatment. So one wonders, or it's an easy question to ask, whether students can be as effective in treating patients, can get the same kind of quality outcomes. It seems they can, and we have another study that I'll show you briefly that supports that. So building out the group program. Here's a third one, school health. So Institute has a school health program and has for a long time. Do we still have that?
Yes.
All right.
Soon to be 7 sites.
7 sites. Okay, so what better place, not part of the clinical patient-physician encounter, what better place to start empowering people to take charge of their health, to understand about managing stress, to understand about eating right and moving? What better place than elementary schools? So this is an amazing organization called Wellness in the Schools. It's a nonprofit. Was started by a middle school principal who kind of decided this was her next work and what she had to do. And they are in, I think they are now, were in 19, I think they're now in 26 or 27 schools in New York City. Their program basically has 3 components. Cook for Kids, they bring in interns to the schools who are culinary interns working with famous chefs. So the chefs force their interns to go do this as part of their program. And they go in, they show the kids cooking techniques, they work with the cafeteria staff to give them some tips about preparing healthy foods. They're actually working with the Board of Education about making a change in the public school menu, which is like moving Mount Everest, but they are working on it. So that's the Cook for Kids program. So it's basically exposing kids to healthy foods and to the idea that you can prepare food for yourself. That's good for you. They also have a movement exercise program where I don't know if people have had kids in the New York public elementary schools, but recess is you go out on the blacktop and you either stand around or you try not to get involved in any altercations. But it's not a really effective way of getting movement into the kids' day, so they're putting coaches out on the playground to organize activities with the kids, and they're doing this in a whole bunch of schools. And then this is the program they haven't got off the ground yet, environmentally safe cleaning products in the schools. I think they're still working on that. But basically, when you talk about how to approach this problem of childhood obesity, how to approach some of the mental health issues we're seeing in kids, why not promote reaching out to them in schools? So maybe that's something else we could think about. Our school health program, I think, is mostly clinically oriented. And can we think about building it out, not with a physician, but with some other collaborators so that we're coming at it from a different point of view? So those are just 3 kind of somewhat out of the box, doesn't make it harder for the clinician, has a potential to empower our patients and give them some skills around handling their health in a different way. Okay, so the last part that I'm going to focus on, which is I'm going in a little more detail, is acupuncture for chronic pain. So as you saw from that ACP article, and we could go on and on about this, acupuncture is one of the best studied integrative health approaches now, and has shown to be very effective for back pain, neck pain, osteoarthritis pain. Problem is, it's hard to figure out how to deliver it. So Medicare, Medicaid, still at this point do not pay for acupuncture. More and more private insurance companies are paying for it, but in an underserved population, that only helps a little bit. So we've got this therapy that we know to be effective. How do we deliver it to our patients? So I'm just going to show you a trajectory of 3 studies we've done, and now leading to a 4th study, hopefully, looking at creative ways to bring this to an underserved population. So the first was using the approach of students. And this was done in the Bronx in conjunction with the Einstein and Montefiore Community Health Center network. Basically, we brought in teams of students to the community health centers and treated people with acupuncture. We had a total of 495 patients referred and ended up treating 226. So the first thing about this study was, how acceptable is acupuncture in the community health center setting? You guys are already over that hump, but that hadn't really been proven. Patients in this population are often not familiar with this. It's culturally not particularly congruent. Physicians aren't experienced. Are they going to refer? We had way more referrals than we could handle, and I'll show you the study that followed on this. And the bottom line of this is We had 226 people go through acupuncture treatment, back pain, osteoarthritis. Please just look at the population briefly to show this is like a lot of our institute population, mostly Medicaid, many on disability, very significant pain. 7 on the BPI pain severity scale is high. People are having pain 12 out of 14 days. And so first of all, people came. Community health center patients, they came for acupuncture. They stayed on average for 8 treatments. So there was no question of, are people going to engage with this? And then just to look at the results, pain severity improved. We followed people out to 24 weeks. And you can look at these results in detail later if you want. But bottom line, 30% of our population experienced a 30% or greater improvement in pain. So when you do pain studies, there's a threshold of, is it really clinically significant change in pain? And this marker of 30% change is what's generally used in studies. So in that particular population, a third of the people had a significant benefit, which went out to 6 months. And the treatment was only 14 weeks. So treatment was done in 3 months, and then 3 months later, they still had benefit. And this was in, where was this? Journal and Board of Family Medicine. So then, okay, great. We can use students. We can be effective. The logistics of having students can be tricky. They have vacations. It can be tough. So what about the question of group acupuncture? The way group acupuncture works is people sit in chairs, generally, hopefully comfortable chairs, although I'll show you what it really looked like in the Bronx in this last study. And one acupuncturist goes around and treats a group of people simultaneously, because for people who aren't familiar in acupuncture, the way it works is you put needles in. Takes 5-10 minutes a max to put the needles in. People sit with the needles in for 30 minutes, give or take. Then you take the needles out. So put the needles in, move on to the next person, the next person, the next person. And one acupuncturist can treat 6 people in an hour, more or less. So these were groups of 6 to 8 people who were getting acupuncture in a group setting. And this is, so the second study, which was sort of another pilot feasibility study, we actually did at the Center for Health and Healing, where I used to work. But it wasn't our patient population. We had a very middle-class, upper-middle-class patient population, but we didn't recruit from our patient population for this. We just used our space. And a lot of institute patients were in this study, actually. And chronic neck pain, back pain, et cetera. This was actually only an 8-week treatment, because part of the goal with this one was how low can we go? How, what's the minimum treatment that's going to work? So we're doing a group. Is 8 weeks good enough? We were really looking for something that would show that a community health center or an organization with limited resources could take this on and provide this care. So we followed people out for 24 weeks. We had 96 people complete the 24-week protocol. Slightly different population. This was just 30% Medicaid and Medicare. So it was a little bit more middle-classy population. And basically what we found was, this is the pain severity on the BPI, and you can see very significant drop, 5 down to 3. This is pain interference. So the brief pain inventory also tells you not just how bad is your pain, but how much is your pain interfering with your life. So the functional part of pain, which we know is very important. Same kind of improvement. And one thing that's really, we were kind of blown away from in this is, so this is the beginning, this is the midpoint when treatment finished, and this is 24 weeks. So the improvement not only maintained, but actually continued to increase. And who knows why that is. But that was a finding that kind of stunned us, that 8 weeks was enough, that improvement not only maintained over 24 weeks, but continued. Oh, 840? Okay, I'm doing it right. And this just goes through the numbers, basically. And here you can see 55 out of 95, that's almost 60%, showed a 30% reduction in pain severity. So basically, group acupuncture is getting used all around the country. This is something we haven't done at the Institute yet, but they have done at other community health centers. When I trained at Monty Family Health Center, actually a long time ago, 25 years ago, there was an acupuncturist doing group acupuncture there. And the model, some of the model actually started in substance abuse treatment, and it started in the South Bronx at Lincoln Hospital, where they used group auricular acupuncture for treatment of substance abuse. And it kind of built out from there. And now there are really hundreds and hundreds of, they call them community acupuncture, practices and clinics around the country. Some of them are not cheap. Some of them cost people $50 or $60 even for a group visit. Some of them are cheap or have a sliding scale. It kind of depends on the motivation of the people running them. So this has caught on very big around the country, including in New York, but nobody had studied it. Nobody had demonstrated that group care was in the same range of effectiveness as individual care. So the exciting thing about this for us, even though it wasn't a randomized controlled study, it was just a one-arm study, is that it showed that group care can be as effective as individual care in people with chronic pain. Pretty exciting. And again, people stayed. The average number of sessions was 6.7, so almost everybody stayed for all 8 treatments. Really very impressive results in terms of pain treatment. We were just sort of blown away. And then interestingly, we also measured depression. As we know, depression coexists so often with chronic pain. And there is some good data actually from England, from controlled trials, prospective randomized trials, showing that acupuncture can be as effective as counseling in the treatment of depression, believe it or not. So we wanted to measure depression in this study too. And we found similarly improvement in depression scores from baseline to midpoint, and then those maintained out to 24 weeks. This wasn't quite as significant a change as we saw in pain, but it was definitely in the same direction. So that's kind of the next thing that has to get looked at, is how effective can acupuncture be in the group setting for the treatment of depression and other mental health conditions. And this came out earlier this year in Pain Medicine. So that was really exciting for us. So what then? There we go. Okay, so here's the third one, and this one possibly has even the most relevance for the Institute and for our practice. So building on the results of the first study that showed we could do acupuncture in the community health setting, that ADOPT study that I showed you, and the results of the second study, which showed that group acupuncture appears to be as effective as individual, but we didn't really know because that wasn't a comparative study. We've been doing a large comparative effectiveness study that was funded by PCORI, which is the Patient-Centered Outcome Research Institute, to compare individual acupuncture to group acupuncture. And this study has happened at 6 community health centers in the Bronx. Believe it or not, we recruited over 700 patients to this study. So once again, showing kind of the demand in our community health center patient population is absolutely there. The willingness to engage with this is absolutely there. This was a 12-week protocol, and these are the practices that participated. Williamsbridge Family Health Center, East Bronx, people perhaps know of some of these practices, but again, very similar kinds of settings, similar kind of patients. And here's the real knockout. This is where the acupuncture was done. Is this like a super cozy, holistic, acupuncture room? Not really. So the individual treatments were done in exam rooms. They did have body cushions, which helped a little. And then here's the real kicker. This is where they did the group acupuncture, because at these places, they really only had conference rooms. So really, people sat in these chairs. They rolled up their sleeves. They rolled up their pants. They got acupuncture in their head, neck, arms, and legs. And that was our group acupuncture treatment. So did it work? We don't know yet because we're just in the evaluation stage. Sorry, I know I really set you up there. So we did enroll 706 patients. We completed data collection. We got 85% retention, which is amazing. We had an amazing staff for this. And we're still waiting for the 24-week data, which will be done in February. So we're very nervous because this is a much more definitive, or I'm very nervous, much more definitive study as far as the effectiveness of group acupuncture. Does it really work as well as individual? Because this would have really big implications. It's one thing for a community health center or a practice with a limited budget to say, we can have one acupuncturist on staff, they can treat 2 patients in an hour, they probably need 2 rooms, and we're gonna sacrifice the revenue that those rooms are bringing in, versus we can have one acupuncturist, they can treat 4 to 6 people in an hour, we can use a group room that perhaps isn't getting used for other things at that time, and we can make this accessible to much, much larger proportion of our population. So I hope it worked. I'll let you know next time I come. So now on to what we're doing next. And what I want to say briefly about this is that this is super exciting because we are now launching a modest but hopefully soon to grow integrative medicine research program in the Department of Family Medicine at Sinai and at the Institute, which is really exciting. We've done bits and pieces of research over the years, but as our department at Sinai Beth Israel kind of folded up, we were able to successfully move our research program over to Department of Family Medicine, thanks to Diane. And so we're really in good shape now. And we're launching our first study and hopefully planning to do a second one. And really the focus of this program is meant to be, how do we effectively deliver integrative health approaches to underserved patient populations? And what's the best way to do it, and what are the best approaches? So the first thing we're doing, which is just now being submitted to Institute IRB, I think just was, and Ray is one of the PIs, similar design to our group acupuncture study, our one-arm group acupuncture study. But now what we're doing is we're adding in a yoga intervention, because there's a sense that you treat with acupuncture, it lasts a certain period of time, but people with chronic pain probably need to be doing more for themselves, some kind of movement approach, some kind of activated therapy to have really durable long-term pain. And there are good studies looking at yoga as treatment for chronic back pain in particular. So we're looking at merging those two interventions. It's going to be a 10-week, 11? You said 12. 12-week total intervention. Hopefully it will be happening at Harlem as well as at one of the Monty sites, Harlem Family Medicine, and as well as at one of the Montefiore sites in the Bronx. We're aiming to get about 150 people in this trial. And again, this is a first step towards hopefully a larger trial where if we can show that this is possible, feasible, patients do it, and we see some effectiveness, then we're going to propose a larger trial where we then compare this to other kind of group care, to yoga alone, to acupuncture. We got to figure out what the next study is. But this is really exciting because this is the first study we're launching with the Department of Family Medicine's Integrative Medicine Research Program. And I want to say regarding that we are very, very much looking for partners, both within the Department of Family Medicine and across the institution, people who are interested in research around complementary integrative health, to kind of join with us and partner on interesting study ideas, particularly as they pertain to underserved populations. And so residents, fellows, researchers in other departments, other family medicine faculty, if people feel interested in this and inspired and want to dip their toe into pursuing further research in this area, we have some ability to do that and support that over the next couple of years. So that's very exciting, and hopefully some other great ideas are going to bubble up. The last thing I want to put out, and then we can have questions if I have any time left, is wonderful organization. So if you're interested in this topic and you want to learn more, there's an organization called Integrative Medicine for the Underserved, or IM4US. This is a national organization that basically is a platform for practitioners across the country who are interested in this subject and working with underserved populations to share ideas about education strategies, clinical delivery strategies, research ideas, etc. They have an annual conference, which happens in August, and this year is happening, do you know where it's happening?
In DC in June.
Oh, there you go. In DC in June. Thank you.
They timed it for Advocacy. I forget what's happening in DC around that time, but it was intentionally earlier this year for Advocacy.
Great, excellent. And I will add that a big thing that's going on now is advocacy around getting better coverage for some of these therapies from Medicaid and Medicare. And this is a huge priority because now that we see the hard evidence Joint Commission requires and our major public insurers aren't paying for it yet, something's got to change. So there's a lot of momentum in this pain world and the integrative medicine world around trying to press for change in that area, trying to get more coverage. There are a number of state Medicaid pilots around the country, mostly focused on acupuncture, that are bubbling up with some good results. So some of the state Medicaids may be covering this, but we're got to push harder. Ray?
And just a quick plug, they had their last conference, where did I go?
Chicago, maybe?
Chicago, thank you. And I was really impressed. They really picked on it.
Yeah, I've been very impressed with it. And just as a little sideline, this is a grassroots organization that actually came out of a group of family medicine docs who work in, what'd you say?
Came out of STFM.
Yeah, it came out of STFM. People said we need to have sort of more conversation about this. It started with weekly phone calls and evolved into actually a nonprofit that's got funders and has a staff and has annual meetings and is really doing a lot of important work. And so that's another example of sort of the kind of activism where you see something that you think is important for your patients, you don't see it happening, you set your eyes on it, and you make something happen. So I think that's it's kind of an inspiring organization in that sense. So I think I've reached the end. So I think just the last thing I want to say is, don't leave this here. Go back to your practices and think about, I'm going to think about integrative health not as one more thing I have to do in my session. Oh my God, now I've got to do a mind-body exercise with my patient. Don't think about it that way. Let's think about it structurally and as a system, and think about what some of these out-of-the-box ideas are for how we can support access to some of these therapies, so that ultimately, as the clinician who's a little overwhelmed, it helps you because you have more tools. So if I can the docs at the Mani Community Health Centers were so upset when the acupuncture study ended because, for 3 years, 2.5 years, they've had a really excellent option for some of their chronic pain patients. And they're wrestling with where can they find the money to hire a group acupuncturist now. And some of the sites may manage and some won't. But it's really meant to be that. It's meant to be a way to build out the team so that the kind of approaches that are open to the family doc or the clinician in that kind of setting become wider and more empowering for the patient and more accessible. Questions or comments from anybody? Red?
This was just an amazing presentation that brought sort of the need for evidence, the role of advocacy, and the fact that there's this way of treating patients that's just been undervalued. And so I have two thoughts. One is, it's also been our experience that having people who work in healthcare experience these therapies can be incredibly effective. So one of the things that we should consider is how to offer these services to employees. And given sort of the issue of whether you want to call it burnout and teaching people resilience, and the fact is, this is a really stressful time to do this work. And one of the ironies is to walk into a community health center to get this kind of care, but to get treated in other ways that really don't support what this experience was like. Going into a place where people can't smile and greet you properly because they're stressed out, but you're there for a yoga class. And I think that kind of discordant experience is something that we should really try to change. So one sort of challenge to think about, and I'd be curious to hear, even if the VA has done this, is how to provide some of these services through something like an employee's health or an educational, teaching people how to deal with stress, acupressure points, that would be one thing. The other thought I had is doing this with the homeless population. And the kinds of things that you're describing so articulately about being able to adapt these techniques to a whole range of different locales. We have relationships, we have a number of homeless sites, and we also have free clinics. So there could be opportunities to think about, again, different research projects. We work with 2 medical schools around the free clinic to see, including Einstein, that we could sort of explore those areas. So those are 2 thoughts I had there.
Yeah. Great idea. Thank you, Red. And so regarding the homeless, if anybody who's interested in that subject should just get in touch with Nikki Naritan, who's been doing this in the Institute's homeless program for a long time, just finding a way to do it. Oh no, definitely to study it would be great. And regarding the first thing you said, Red, there are a number of large health systems, Allina Health System in Minnesota, for example, that have decided to pay for some integrative services for employees and are trying to measure the impact on things like resilience and absenteeism and that kind of thing. I know Sinai even is offering some wellness services. There's some yoga classes, there's some meditation classes. So it definitely seems like there's a movement in that area. VA is trying to do that too and trying to figure out, as everywhere, the hardest part is figuring out how to liberate time. So you take people out of their clinical practice, suddenly, you've got more demand, you've got access problems, but at the same time, you really need to. So we're also trying to figure out how to do that efficiently. But absolutely, positively a crucial part, I think, of the equation. Any other questions or comments? Yes.
You mentioned the trial of group acupuncture that you're still in the stage of either collecting data or analyzing data for those results. Just curious if you're aware of other similar trials to that going on, and what you might anticipate as the next step, although I realize that might depend partly on the results, but are there other big questions about providing access to this that would be kind of the next step in terms of additional trials?
You mean acupuncture in particular?
Either acupuncture or other integrative.
Yeah. So there are certainly other. So there are other group acupuncture trials, smaller ones. There are a lot of other trials looking at group-oriented integrative medicine approaches, mindfulness, teaching, et cetera, and comparing to kind of behavioral therapy, et cetera. As far as I'm aware, there isn't a lot that's really explicitly focused on underserved populations and on economically challenged areas. So I think that's an area where there's a real need for more. And in terms of what comes next, I hope what comes next, if group acupuncture works, or maybe even if it doesn't, and we can pull off our current study looking at the fusion of acupuncture and yoga, and get some interesting first-level results. I would like to go to another comparative effectiveness trial, whether PCORI is still around or it's, NIH or somebody else, but I would love to see us do a similar trial. Either if group acupuncture works well in the Bronx study, maybe compare that to group plus acupuncture plus yoga, or if it doesn't work, maybe just acupuncture plus yoga to individual or something. Because I think what we're trying to do is home in on what approaches are going to work the best. And, research is challenging because you have to tackle one question at a time, and it takes 2 or 3 years to get the results. And so it's slow, as you know. But I think that's where I'm hoping. I'm hoping that we continue to focus on pain and maybe somewhat on mental health in our research program, because I think that's where you have to go where the strongest evidence for these things is. So, whether it's mind-body interventions, acupuncture, et cetera. I think that's hopefully where we're going to go. All right, I think we might be done. Thank you.